Good afternoon. My name is Bryan Sandler, and I've been asked by the organizing committee to present on is there a need for specialized privileging and training within the endoscopic realm of anti-reflux procedures? Specifically, which endoscopic anti-reflux procedure should I offer my patient? I'd like to thank the panel chairs for the opportunity to speak. My disclosures: I'm a speaker and consultant for Boston Scientific as well as a consultant for Intuitive Surgical. Neither of these will have any impact on my topic today. The adoption of new techniques and new technology continues to be an issue within surgery. The U.S. Food and Drug Administration does not regulate new procedures as it does with new drugs and devices. This has led to widespread adoption of some techniques without the tried and true randomized clinical trial. There have been several very successful adoptions of new techniques and technologies, some of which are listed here: laparoscopic appendectomy, cholecystectomy, CABG, ERCP, endoscopic surveillance for cancer. But balancing that out, there have been many failures of the widespread adoption for several surgical technologies. The adoption of new techniques and new technologies in surgery has an implied promise that the newer techniques, the newer technologies mean that they're better. Malcolm Gladwell, in his landmark publications, describes the spread of ideas, products, and messages like viruses through word of mouth epidemics. These different ideas are spread by mavens who can gather information and pass it along to others, connectors who are sociable and bring people together, and salesmen who have a talent for persuasion, promoting the idea. It allows for the diffusion of ideas throughout a population, which accelerates, as you see in the bottom right-hand corner, to a tipping point somewhere around 10 to 20% adoption, after which the idea becomes widely adopted by the majority. There's an S-shaped learning curve or spread of this, with the early innovation performed by those early innovators. The early adopters then follow, after which that critical mass or tipping point is reached, usually then followed by the early majority, a late majority, and the laggards. When we look at surgical techniques, laparoscopic appendectomy is an example of this idea. Originally described in the 1990s, it perhaps reached that critical tipping point somewhere around 2003, 2004, where its efficacy was still being proven. It was widely then adopted by many and stabilized in its popularity, frankly, in this case, without the need for randomized controlled trials, which may or may not have been successful in proving its efficacy. Within endoscopy, SAGES has led the way. In June of 2016, SAGES put out privileging and credentialing guidelines for physicians in GI endoscopy. Privileging is mostly a local and regional responsibility. The SAGES guideline recommends completion of a formal training with GI endoscopy as a specific portion of that training. So think surgical residency completion, medical residency completion with fellowship in GI completion. However, it recognizes that endoscopic training can be gained outside of this formal residency program. However, short courses that don't have the typical hands-on training as well as appropriate patient care experiences and proctoring are not adequate for privileging perspectives. The guidelines go on to explain that initial credentialing should be followed by early skill assessment and outcome evaluation by the provider. Following this, ongoing professional practice evaluation, or PPE, should continue periodically throughout one's career, along with tracking of outcomes to maintain adequate safety and efficacy. And that renewal and maintenance of privileges should include an assessment of quality metrics, complication rates, procedural completion rates, appropriateness of follow-up recommendations, are some examples of these quality metrics. ASGE also has its own endoscopic guidelines. This document, which was published in Gastrointestinal Endoscopy in 2017, actually broke out several different subsets and sub-skills that give specific recommendations. So moderate sedation is a specific skill, EGD is a specific skill, ERCP, EUS, EMR, deep endoscopy, endoscopic enteral tube placement. All of those listed here were specific endoscopic skills spelled out in the ASGE guidelines that help a privileging body identify who is a candidate for these skills and who can be granted these abilities. It further went on to define and outline emerging technology and found that major versus minor skill acquisition, or defined major versus minor skill acquisition. A minor skill in the ASGE guidelines is an extension of a accepted and widely available technique. So something like a new clip or a new over-the-scope clip or over-the-scope technology that is based upon preceding over-the-scope therapeutics like banding. RF ablation of Barrett's, again, which is an over-the-scope ablation through existing over-the-scope techniques. Some of these minor skills require simply an education, some form of practical exposure, i.e. a short course, training videos, simulator experience, maybe all of these, after which the skill would be implemented and acquired by the provider. Contrast this with the major skills the ASGE guideline spells out as new techniques or procedures that involve a high level of complexity, interpretive ability, and/or a new type of technology. So learning POEM from someone who does basic endoscopy, learning ESD or EMR as a skill set for someone who has already performed basic endoscopy skills. In these instances, short courses are not necessarily adequate as they lack the appropriate patient interaction and management and interpretive skills. And instead, a preceptorship model is a better means to ensure this major skill acquisition has been attained. Along with this, proctoring is absolutely a requirement and is spelled out in their guidelines. So when we look at endoscopic GERD therapies, the most common are listed here. We can decide as a privileging body which of these are extensions of pre-existing skills or tools. So that would be in line with that minor skill acquisition versus which of these are major skill or technique or technology acquisitions that would require then a more formal training pathway, a mini fellowship or the like, that would then be implemented prior or be completed prior to skill implementation or skill privileging by the provider. So in summary, endoscopic societies should provide new technology assessments in a timely fashion that spell out minor device or minor procedure modifications. Surgeons and endoscopists should self-monitor their outcomes and complications for these minor device and procedural changes so that they are safely implemented and can be applied to their practice in a safe manner. Surgeons and endoscopists should exercise self-assessment and self-regulation when introducing new technologies and techniques in their practice um, to ensure patient safety. And institutional credentialing bodies, new technology committees, and institutional IRBs should monitor their clinical introduction to safely ensure the implementation of more major skill acquisitions and skill developments, as these may require a more intensive training like a mini fellowship or otherwise. I want to thank the organizing committee for the opportunity to present. Thank you very much.